Hello. So I would like to thank the organizers for inviting me and Pfizer for organizing this lecture. So this is about inotuzumab in real world. Does it perform at the same level or better or less than what's reported in the clinical trials? So this is a disclaimer from Pfizer. And this is my agenda. We'll go over a little introduction, then go over some evidence from real-world data and a conclusion. So this is a slide that I usually share with our students. This is the development of therapeutic in ALL. As you see, in 1948 was the first successful result with ALL. This is a complete remission achieved by aminopterin. Aminopterin is methotrexate, basically. It's antifolate. And it was a New England Journal of Medicine publication, as you see over there, by Dr. Farber, the founder of Dana-Farber Institute. So that was the first success. And then later on, new drugs came over, like adrenocorticotropic hormone, so basically steroid, 6-mercaptopurine. And then people started to combine these and found out that combination is better than sequential. And then later on, vincristine, which was evaluated as a drug for diabetes, actually, by Eli Lilly, was found to have effect on the marrow and then used in combination with the other drugs. And then we started to see some long-term survivors. Then the VAMP protocol by the National Cancer Institute, vincristine, aminopterin, so basically pump regimen. The pump regimen led to 88% complete remission rates. And then when they used pump regimen for about a year, they observed some cures. Now, when long-term survivors survived, we started to see CNS relapse. So this is how we discovered that the CNS is a sanctuary site for ALL. We need to address the CNS, and this is how we started to use ITs in these patients. And then in the 1980s, the combination chemotherapy protocols, specifically pediatric protocols, extended protocols, and ITs were all fine-tuned to achieve a level of around 80% cure rate with the pediatric protocol. In the 2000s, we got the TKIs and immunotherapies, which is one of the biggest achievements in the treatment of ALL. So here on this slide, you see the immunotherapies in ALL and the registration studies that led to the approval of these drugs. First, you see the Tower trial, which led to the approval of Blina in relapsed refractory ALL. Then the Innovate, which led to the approval of inotuzumab in relapsed refractory ALL. Blast was a phase 2 trial that led to the approval of blinatumomab in MRD positive disease. And then, of course, you know now about the CAR T-cell. We have two products. We have one for the young patients and one for the older patients available on the market. So now also these targeted therapy are being used in the front line, combined with different chemotherapy backbone. Here you see the hypercivad blina inotuzumab from MD Anderson. Very good results are achieved with these combinations, but still we don't have labels for these indications in the front line. This is also done for elderly patients who cannot tolerate chemo, cannot tolerate intensive chemotherapy. Also very good results have been reported by MD Anderson, but still this is not a labeled indication for the drugs. Now, with the use of these immunotherapies, we learned about their side effects. So we learned about the ICANS, neurotoxicity, and cytokine release syndrome with the pure immunotherapies like Blina and CAR T-cell. And then with the ADC antibody drug conjugate like ENO, we learned about the SOS. So here in this trial done by Dr. Kentarjian, you can see the SOS incidence was 11% with inotuzumab versus 1% in the standard of care patients. So this SOS was also exaggerated in elderly patients who are elder than 55, or patients who took double alkylating regimen as a conditioning regimen. So we learned about all of these, and the question is whether real-world evidence reflects these findings or different findings. So the real-world evidence utility actually is to see when people apply these drugs in a real-time setting rather than clinical trial controlled where you have inclusion-exclusion criteria. You have to stick to these. In real-world evidence, you decide to treat your patient depends on your judgment what's best for your patient. So this is the first study reported from US. Basically, it's from 11 centers in the United States. 84 patients were collected. So these are patients treated with ENO for relapsed refractory adult ALL, and treated with the regular dosing, 0.8, then 0.5, and then if NCR, 0.5, 0.5 for the next cycles. So this is the baseline characteristics. Here you can see the median age of 50, so kind of elderly population, good performance, and you can see that around a third had Philadelphia positive or translocation 411, so the higher risk disease. In terms of CNS disease, 11% had CNS disease at diagnosis, and 25% on the relapse setting. So this is the treatment characteristics of these 84 patients. Here you see that a quarter of them, 25%, had primary refractory. Prior Blina, 48%, so almost half of them had prior Blina. 27% had prior transplant. And as you see, some people were treated with chemotherapy, so ENO plus chemo or TKI. And the median cycles of ENO received by these patients was 2, and you will see this number coming over and over in the next studies. So in general, this drug is given as a bridge for transplant, and in general, people would get around 2 to 3 cycles to bridge them. Now, some people are not candidate for transplant, they'll keep going, and that can go up to 6, 8 cycles, depends on the tolerance and the disease response. So here's the result, 63% CR/CRi. So that is close to what's reported by the Innovate. The Innovate, the CR rate was in the 73% range. And of these, 36 were MRD negativity. So 36 out of 51 is around 79%. The Innovate trial, the MRD negativity was 80%. So pretty much in terms of efficacy matching what's reported. And you can see in different categories, like in Philadelphia positive, the CR is 73%. Patients who were refractory to chemo, so they got chemo, were refractory, 60% the CR rate, and so on. So a quarter of the patient proceeded to transplant, and all these patients received the prophylaxis for VOD. So they received ursodeoxycholic acid. 2 patients died at day 100 after transplant, but not both from VOD. So we will see here the results. The duration of response is 11.5 months. And as you see here, for transplanted versus non-transplanted patients, the duration of response was higher for patients who were transplanted. And here, if you want to talk about statistical significance, so they did multiple risk factors and checked if these are related to the duration of response. And as you see, if you go over the p-value, none of them was significant. So the duration of response was similar among all these group of patients, whether they were allotransplanted or not, they received the prior allotransplant or not, they were refractory, Philadelphia positive or CNS positive disease. So they enjoyed the same duration of response regardless of the baseline characteristics. In terms of overall survival, the median OS was 11.6 months, and that's better than what's reported in the Innovate. The Innovate trial reported 7.7 months as median overall survival, which can be here because of the selection. So patients are better selected dependent on the results of the Innovate, and as such, they can withdraw more benefit from the drug. Now, the overall survival was better in Philadelphia positive patients, as you see here, as compared to the other population. And whether the disease was refractory or not, the overall survival was the same. So refractoriness did not affect the survival. And here you can see the multivariate analysis, and you can see that Philadelphia positive patients did better than the others, as you see with a pretty significant p-value. MLL gene rearranged patients, they did not do well, okay, so with ENO. So the other risk factors, they basically behaved the same. The overall survival was the same, whether the patient has the baseline factor or not, like allogeneic transplant before ENO or CR1, CR2, so they did have the same survival. But Philadelphia positive patient did better than the others. MLL did worse than the other, and MLL is very well known risk factor for worst outcome. In terms of toxicity, so the most frequent toxicity was liver toxicity, but not all VOD. Only 3 patients had VOD, so 4%. And this is an opposite to what's reported in bigger trial, prospective trial, and this is probably reflects the selectivity. So the selectivity of the patient, the better preparation of the patient. As you know, in Innovate, it showed that elderly patients, patient with baseline liver disease, patient who got transplanted with double alkylating had worst incidence of VOD. So probably in real world, people select their patients and avoid these risk factors and prepare their patient, and this is why the VOD was less. As you see, the fatality was only 1 case due to VOD. So only 1 patient died from VOD. Now, the limitation, of course, is retrospective, so selection bias is built into these retrospective studies, but it reflects that the drug performs, in terms of performance, the same, and safety may be better because of the better selection of these patients. What also was impressive in this is the fact that Philadelphia positive patients do better than others with ENO, though Philadelphia positive is a known risk factor or higher risk factor in ALL. Liver toxicities were the most common, but all were grade 1 to 2, except 1 patient, as we alluded previously. So this is the other trial. This is kind of economic trial. So this is comparing ENO to FLAG-IDA. As you know, FLAG-IDA is one of the salvage regimen in ALL. So this trial compared ENO to FLAG-IDA. What they did, they reviewed 40 consecutive cases who received ENO or FLAG-IDA, so relapsed refractory ALL, ENO or FLAG-IDA, and they compared the economic impact of the both approaches. As you see here, this is the baseline characteristics. Age was little higher in FLAG-IDA, 23 years old, the median age. Disease status, as you see, more refractory cases in the FLAG-IDA, but more cases received 3rd and 4th line therapy in the ENO arm. In the FLAG-IDA, the majority of patients received 1 or 2 therapies before FLAG-IDA. In terms of transplant, as you see, 5 patients were transplanted before ENO on the ENO arm and 0 patient for FLAG-IDA, and that was the only statistically significant variable that's different at baseline. Here you can see the number of cycles received. Again, on average, the patient received 1 to 2 cycles of ENO, and as you see the outcomes. So you see the infections much higher in the FLAG-IDA, the inpatient days much higher in FLAG-IDA, and all statistically significant. In terms of bone marrow suppression and support for bone marrow suppression, all the variables were in favor of ENO. So basically, you need less inpatient admission, you need less support in terms of transfusion, you get less infections with inotuzumab as compared to FLAG-IDA, and this is very well known factor because FLAG-IDA is very immuno and myelosuppressive. So again, this is a retrospective study, and sample size is small, so this is why these are the limitation. But anyway, it does show that you need less days of admission and less use of supportive care measures with inotuzumab. This is a retrospective study from UK as well. So again, retrospective studies of patients treated in UK with inotuzumab from 4 centers in the UK. And here you can see the baseline factors like exclusion, inclusion of the patients. Here you can see the baseline characteristics of these patients. So limited number of patients, 28 patients. And as you see, 14% were Philadelphia positive. 3/4 were in first relapse, so kind of early use of inotuzumab rather than late use. And the other impressive characteristic is the number of transplanted patients prior to INO. So a third of these patients received a transplant, relapsed, and then received inotuzumab. Here you can see the overall survival, 11.7 months, so matching the prior retrospective study and little higher than the randomized INNOVATE trial, which was 7.7 months. And as you see, the CRI rate was 69%. So this is always the rate we're getting, around 70%. In terms of MRD negativity, 14 out of 18 patients had MRD checked. And of these, 11 were MRD negative, so 79%. So the same numbers are being repeated and repeated, in terms of CR, around 70%. And of the CR cases, around 80% are MRD negative. Median overall survival, 11.7 months, as I said earlier. So here's the per patient who received or did not receive transplant. As you see, the overall survival was way much better with transplant, 22.8 months versus 6.6. And on the second graph, you see the overall survival by number of relapses. And you see a patient who relapsed early enjoyed a 12.3 overall survival benefit versus 4.9 in second and further relapse. So using the drug earlier in the relapse setting would be better. In terms of safety, again, we talk always about SOS with inotuzumab. And as you see here, one patient died from SOS complication after transplant, and another patient died actually from SOS, but did not receive transplant. So one was post-transplant, was one prior to transplant. And as you see, after inotuzumab, around a third of patients were able to proceed to transplant, so they were in remission and went to transplant, and 7 patients received CAR T-cell therapy. So again, in this sample, the treatment with INO matched what's reported in clinical trial. Safety-wise, it looks like less SOS than what's reported in trial, and that's probably because of the patient selection and prophylaxis and the fact that these decrease the SOS incidence. So this is specifically after transplant. So this is another retrospective study. We have 2 studies, and then we'll finish. So this is a patient who were treated with inotuzumab and then got transplant. As you see here, the characteristics. So median age 42, good comorbidity index. You see the Philadelphia, 18% Philadelphia positive, 18% Philadelphia-like, and the others are Philadelphia negative. Again, they did review these patients looking into the VOD incidence, small number of patients. You see the number of cycles. We said always 2 cycles, and you see here 13 of the patients received 2 cycles, so that's the median number of cycles. They did wait on average 1.9 months to transplant these patients, and this is what we do in clinical practice. So we delay the transplant after the last dose to decrease the risk of SOS. Conditioning, as you see, all the conditioning did not contain double alkylating, again, because double alkylating increased the risk of VOT. Donor type, as you see, the majority are matched unrelated. So basically 17 patients were reviewed here. Sorry, I went back, I think. Can we go back? How can we go back? This one? Yeah. So median number of cycles received for transplant are 2 in these 17 patients. 10 patients achieved CR with an overall response rate of 76%. Again, the same number. No patient developed VOD after allogeneic transplant. again reflecting the selection bias and the preparation of the patients before giving inotuzumab and taking them to transplant. Median overall survival, 21.2%. So the absence of VOD in this population may be attributing to limiting the number of inocycles. So on average, they give 2. Okay. Also, they delayed the transplant for 2 months, and this is what we always do. And they avoided double alkylating agent, and this is what we do in a clinical practice. Of course, we need large data set and the prospective trials. This is a CIBMTR retrospective analysis. This is the largest published in this setting. So this is patients transplanted after INO and reported to the CIBMTR database. As you see, a good number of patients, 131 patients. And the median lines that these patients received were 4 lines for the relapsed refractory setting. So heavily treated population. You can see the disease status as transplant, CR1, 46%, CR2, 13, and so on. Good performance. Majority received myeloablative conditioning, and you see the HLA typing of these patients. As usual, matching unrelated are the most frequent. Now, in about half of these patients, 48%, the inotuzumab was given as a single agent before taking them to transplant. And as we said, the median time to take them to transplant was 2 months, as you see on the last line here. So this is what we do in practice. We wait a little bit to avoid VOD. So the overall survival at 1 year was 55%, and among both relapsed refractory patient and the relapse rate was 21% or 23% for these patients. GVHD, 7 out of 24 patients developed a GVHD, so that's 29%. VOD, 25% as well. And after transplant, the majority were still in CR, above 80% consistently in this population. Here you can see the safety. So VOD, the first 100 days, occurred in 13% of these patients, and no difference was observed regarding the number of cycles received. So regardless of the number of cycles, the incidence was the same, not statistically significant. And the median days for the VOD, the onset of VOD was 12 days, and this is what's usually reported. It's 12 to 15 days after transplant. This is where you observe VOD happening. Now, post-transplant, the VOD mortality, if VOD happens, the VOD mortality is high, as you see, 38 to 41%. So again, so this study reflects what's reported in Innovate and the prospective trials in terms of toxicity. So it's about the same. It's not less like the other trials. And the efficacy was not checked on this trial specifically for INO use. It was checked only to see post-transplant what happens with the VOD. So take-home messages from all this real-world experience. The activity of the drug overlaps what's reported in trials. The safety is consistent, so the alarming safety problem is the SOS. However, the majority of retrospective studies reported less SOS, and this is probably reflects the experience we're building and the selection of patients to avoid this complication. So careful patient selection is essential to avoid this complication post-transplant by minimizing the number of cycles, by delaying the last cycle at least 2 months from transplant, and selecting young patient, avoiding double alkylating. Probably you minimize the risk of SOS to the minimum possible. With that, I will finish. And this is from Pfizer, drug information. And thank you all.